year means an awareness month for PH Association. We have a couple of raising awareness programs, not only in Europe, but all over the world, from the US to Australia. And we firmly believe that on top of raising awareness, providing reliable, up-to-date information is another key mission of PHA Europe. I do not want to take away more additional minutes from our valuable speakers, but would like to ask you that once you have a question, please raise it in the chat box, because after the sessions there will be a Q&A session where your question can be answered. So Marion, the floor is yours.
Okay, thank you very much, Gergely. I will try to put my slides on. Wait a minute, it's not working properly. Okay, do you see the slides?
Not yet.
Not yet. Okay.
Let's try now.
I am a presenter, so...
Yeah.
Okay. You see?
Yes, fantastic. Thank you.
Okay, you have the slides. Okay, thank you very much. And it's a pleasure for me to present you an update on chronic thromboembolic pulmonary hypertension from the 11th Task Force of the World Symposium on PH, who was in Nice in 2018. And myself, I'm from the University of Leuven in Belgium, and you see my hospital on the picture. I'm also a board member of the International Cteph Association and part of the European reference networks in Europe. So first, let me introduce you to chronic thromboembolic pulmonary hypertension, to the disease itself. It's the fourth group of the PH classification. You see chronic thromboembolic pulmonary hypertension, and it has been defined by an increased pulmonary arterial pressure of more than 25 as other causes of pulmonary hypertension. The VQ scan, and we will come back on these two examinations, is abnormal, as well as the CT scan and the angiography, and this after more than 3 months of anticoagulation. What is the cause of the disease? We observe a history of pulmonary embolism in 75% of the patients. And most of this time, these pulmonary embolism are massive or repeated. A pulmonary embolism is a clot which is coming most frequently from the legs, which is coming in the heart and will nestle in the lungs. And it will cause a deprivation of blood in this part of the lung. And normally it resolves very easily and completely without sequelae. However, in Cteph, it's not the case. And you can see here that the material from pulmonary embolism, which is a clot, like you will see if you bleed, and you have a chronic thromboembolic pulmonary hypertension on the right side, you can see that it is most fibrotic strands which are placed in all the branches of the pulmonary circulation. So a very different material, and it is occurring in a certain number of patients after pulmonary embolism, which is not completely clear. It is something in between 0.5% and 3% of the patients having an acute pulmonary embolism. The other problem is that chronic thromboembolic pulmonary hypertension can be misdiagnosed as pulmonary embolisms. So we observed in different studies signs of pulmonary hypertension already present in the majority of the patients with pulmonary embolism, who will later be diagnosed with chronic thromboembolic pulmonary hypertension. Most of them, it's 57%. And you can see in these patients at the time of this diagnosis that The echography is already abnormal with a high pressure and dilated right heart. And also the CT is already abnormal with dilated right heart and signs of chronic vessel obstruction. Now, it is a rare disease, but it is also clearly underdiagnosed. We can calculate an incidence of Cteph of 13 per million inhabitants per year. And this is based on the fact that we know that maximum 3% of the patients after pulmonary embolism will have Cteph, that pulmonary embolism occurs in 1 in 1,000 inhabitants per year, and that 43% have not yet a Cteph. And so when we multiply this number, we come to 13 per million. This is a theory. In practice, we observed an incidence of 5 to 6 per million inhabitants per year from registry data, including most of the patients like in UK. So what are the mechanisms now? Transforming a patient with acute PE to a patient with chronic thromboembolic pulmonary hypertension, and this problem is so the unresolving pulmonary embolism. There are different propositions to explain this phenomenon. An abnormal clot formation of dissolution, you see here a clot, inflammation or infection like in the joints, in the bowel, and so on. The removal of the spleen is also related to the disease, and also a deficient recanalization by new vessels in the clots. As you can see here, all these points are new vessels coming in this fibrotic material, and also some genetic anomalies have been recently recognized. Now, what is the mechanism of the disease itself? So beside this unresolving pulmonary embolism, like you have here this clot and then the obstruction of the distal branches, you have an increased pressure in the vessels, which leads to what we call remodeling of small vessel, which increasing wall size, as you have, you know, from the disease. And this causes small vessel arteriopathy, also called microvasculopathy, of the very small vessels. Now you see here, these are vessels which are also sick in idiopathic pulmonary hypertension, and it gives these aspects. So you have here a clot blocking the branch to the lower part of the lung, and you see that here the normal branching of the vessels is disappeared. This is a disease in the very periphery of the lung. Now, how do we have the diagnosis for Cteph? This is the diagnostic algorithm which has been proposed at the last World Symposium, and it starts with symptoms, signs, and history suggestive of Cteph. What are they? The symptoms at diagnosis are mainly shortness of breath. You recognize yourself or your patients which have problems first in the stairs and afterwards also on flat grounds. They have edema, they have fatigue, and which is specific for Cteph, they have also, for some of them, bleeding in the airway, which we called hemoptysis. And one important problem is that you see that the symptoms to diagnosis, the time between the symptoms and diagnosis is quite long, more than 1 year before these symptoms are recognized. And why is it? Because after a pulmonary embolism, dyspnea, shortness of breath, new or increased, is quite frequent. It's in 1/4 to 1/3 of the patient it is present, while the chronic thromboembolic pulmonary hypertension occurs in these two series of patients, very few cases. So it is normal that the doctors think that it is related to more frequent disease or conditions like advanced age, larger BMI, smoking, a history of a heart and lung disease, before they begin to think to chronic thromboembolic pulmonary hypertension. Now, we have also associated conditions, and you know there that the relation with recurrent and massive PE is quite important. It is observed in the majority of patients with Cteph, while it is not in idiopathic pulmonary hypertension, and it increases the risk of having Cteph by 14% if you have recurrent VTE. You see also that you have non-O blood group. You know the blood group A, B, and O. When you have O, there is also more chance to have Cteph. And rare condition like a pacemaker or a shunt between the head and the heart because of hydrocephalia, and also splenectomy, the removal of the spleen, are very high risk factors for having the disease, but they occur in very few patients, only 4 to 6% of the patients, sometimes even less. The next step of the diagnosis is to having an echocardiography in order to show that you have pulmonary hypertension, like high pressure, and a dilated right heart, which is larger than the left heart. The next step is the VQ scan. The VQ scan, which I show you here. This is the V for ventilation, the Q for perfusion. And when you compare the contour of the lungs, you can see here that there is a place where there is no blood coming. And this is the place where the obstruction is placed. And you see it also here. When you have these two examinations showing pulmonary hypertension and VQ scan anomalies, you have to refer the patients to an expert PH team. And what is an expert PH team? Cteph team is composed of an assembly of doctors specialized in this different domain, the intervention for the balloon dilation that we will see later, a surgeon for an operation, a PH expert, a specialist in pulmonary hypertension, and a good radiologist. They all come together to see what is now the best approach for the patients. And they will have to look at very high quality examination, both measurements of the pressure in the lungs and also of the imaging of these clots to localize them. And these are these high specialized imaging. You see here the CT scan. This is white, is normal pulmonary artery, and you see a black spot, which is a clot, which is thrombotic material here in another view. And the next examination is angiography. This is a normal angiography, and you recognized what you know from the pulmonary circulation, this branching pattern like a complete tree going up to the periphery of the lungs, while in a patient with Cteph, there is an occlusion of the branches and the blood is not going up to the periphery. Here are the obstructions that should be relieved by surgery. We have also more precise techniques. So we have described a lot of lesions which are typical for chronic thromboembolic pulmonary hypertension, complete occlusion, the ring-like stenosis, which are preventing the blood from going to the periphery of the lungs. This is very well described. And we have here also a slide from a Japanese colleague showing that combine CT, it's a very new technique of CT, showing that you can precisely describe the type of lesion in the vessel. This is a slit, a long now separation here, and this is a web with all these different matching net in the vessels. Now, what is now the treatment for the disease? So 10 years ago, we had only surgery. And today we have surgery. We have balloon dilation, I will come back on that. We have medical therapy. We have the combination of surgery and angioplasty. And we have also the combination of the medical treatment with the surgery and the angioplasty. So it's quite complex. That's why we need this expert team. This is the treatment proposition. So you diagnose, you give anticoagulation for lifelong to all the patients with Cteph. And then we have this expert board, which is looking and deciding if the patient is operable. And then we will propose a pulmonary endarterectomy. And if it's not operable, we have another strategy, which I will describe later on. So what is this pulmonary endarterectomy? You see here the pulmonary arteries on both sides, on the right side, on the left side. They are opened by the surgeon. In the back of the vessels, he will take a resection plane, and he will then do all the circles in order to remove a cast from the pulmonary circulation. And this is the type of material that you have already seen, with all this cast removed from the vessels. This is another image, and there are two types of material. The one which is started in the big vessels, which is easy to remove by the surgeons, and the one which is already deep in the lungs, very small obstruction, which are more difficult. And this gives you the type of material which is removed. This is easy, most easy type of disease for the surgeons, while this is already what we call a segmental level. It's already a division of the vessels, which is now feasible. And then you have subsegmental, which is quite difficult and only accessible to the best surgeons in this domain. And so this is the results of the international Cteph registry, the results on the pulmovascular resistance. This is a way to measure the level of obstruction in the vessels. And you see that we have 68% reduction of the pulmovascular resistance after surgery in the European cohort. Of course, it's not an easy operation and there is a lot of complication. Nearly 1 in 2 patients have complication, and they can be mild to severe. It's infection, it's persisting pulmonary hypertension after surgery, can be neurological, can be water under lungs, it can be bleeding, it can be water around the heart. Most of them are quite soluble, and that's the reason why the patients are not awake just after the surgery, but are let in sleep until these problems are almost solved. Now, there is, of course, by many surgeries, there is a risk of mortality. And these are the numbers from the Cambridge experience, from the San Diego group, and this is from the European registry, including 17 centers. And you see that it's less than 5% and even 2% in the most experienced centers of the world. At long term, the survival is quite good in the operation of patients. 90% survive 3 years, while if you are not operated, the survival in this European registry was only 70%. You have to see that this was published in 2016. Since then, there has been much more efforts in the treatment, like the surgery, like the angioplasty and the medical treatment. Now, if the patients cannot undergo an operation because of lesions who are too difficult to reach or because an important cardiac or lung disease, the patient is declared non-operable. Also, some patients after surgery have persistent pulmonary hypertension. And what is then what we propose is first the medical therapy. And the medical therapy is with about the same drug than for idiopathic PH. You see here the 3 studies who had been performed in Cteph. One with bosentan, one with riociguat, one with macitentan. So this is Tracleer, this is Adempas, and this is Opsumit. Duration was almost the same in all the studies, and the effect was significant for improvement in the 6-minute walking distance for the 2 last, not for the first one. And the hemodynamic effect, which means the decrease in PVR, was in the best case only 31%. We have for the medical therapy different groups of patients. The one who are inoperable because the clots are too far, the one persistent as we have just mentioned, but you have also patients refusing surgery, patients who are not operable because of important lung disease, patients who have surgery proposed but who have very severe pulmonary hypertension, and the same for BPA. And for these patients, we have no data on the efficiency of the treatment. We have only data on the first 2 categories of patients. This is the first drug which has been studied with success for the Cteph, which is approved. So Adempas, you know, there was a significant improvement in the exercise capacity, the 6-minute walking distance. And this is the second drug, Opsumit, which is not yet approved for Cteph, but which show also significant improvement of the exercise capacity. Now, still for these non-operable patients, you see that in the current treatment algorithm, we have put BPA very high in comparison with the previous algorithm. And what is BPA? BPA is this angioplasty, balloon dilation of vessels. And this is the principle. So you see that you have a vessel which is obstructed. You put a wire in one of these channels, and this wire, you put a balloon, you inflate the balloon, and this balloon is pushing the material which was inside to the side, and the blood can come back in these vessels. So you see here another version, you see the web, the meshing here, and you see that the wire is pushed, and then the balloon, and you see that from the mesh you go to an open vessel. And this is an image from our Japanese colleague showing you how the obstruction is proximal. And if you go farther, you will see that the vessels in the distality of the lungs are completely normal. That's why we can help patients with surgery or with angioplasty, because the periphery of the lung is normal. Look what we see. We go in this mesh, and then we come in the region where everything is again normal. So if you have relieved the proximal obstruction, you can have a normal vessel behind. This is a demonstration of, again, I think it's image from our colleague Matsubara from Japan, showing you here on the left side, the vessel as it is initially. So you see the injection of the contrast, and there is very few vessels in this part of the lung. In the middle, you see the balloon dilation. You see the balloon is coming, and then at the end of the balloon, you had a small inclipping, which disappeared by the inflation. You can see it the third time. Okay, and then what is the result afterwards? Well, you see all these vessels are back open, and you have a decrease on the a decrease of the pulmonary vascular resistance as a consequence. Now, these are the studies published on this disease. I don't want you to look at all this table. I just let this different study disappear. What I want you to look at is the effect on the PVR, which is as a median in all these studies of 55%. We have to say that our Japanese colleagues have better results and more experience than us. And in Europe, we have a bit lower effect, but in the best case, it's 55%. But still, you see, there is a mortality. So mortality of 1.8% is nearly comparable to the one of the surgery. But of course, you have to recognize that in the latest and the most experienced group, there is no mortality anymore. This is a phenomenon of learning. And when the technique is perfect, you have much less risk of mortality. The complications are described here. During the procedure, you can have a vascular injury causing hemoptysis. Hemoptysis is just bleeding from the airway. You can have a vascular tear, vascular dissection, allergy to contrast, and also some allergy to the local anesthesia. After the procedure, we have what we describe lung injury, and you will see how it looks at the chest X-ray. It's a white lung. It's causing also a decrease in the oxygen in the blood. You can have renal effects of the contrast, and also some bleeding at the access site where the catheter is inserted in your body. And this is these lung injury images. You see, this is a normal lung. This is a white lung. Here you see the scanner. The black is normal. The white is abnormal. It's blood, it's fluid, which is outside the vessels. Most of the time, this can be solved easily by inflating the balloon in the vessel where the bleeding is coming from, and there is few need to intubate the patients or ventilate the patients. Now, this is to summarize what we can do for this disease. So we have on the left side the large vessels, proximal, close to the heart, which are aimed to be treated by surgery, intermediate by BPA, and the distality by medical treatment. Remembering the effects we have seen in the study, 68% for the surgery, 55% for the angioplasty, and 31% decrease in pulmonary vascular resistance with medical therapy. There is also a discussion about the limit between surgery and angioplasty. This is something which is not a straight line in opposition to what I mentioned before. It's a gray zone. A good surgeon will go up to here. A very good angiographist and radiologist will go up to here. And so, depending from the local expertise, one or the other treatment will be preferred. Another discussion is if all the patients, not only the inoperable, should have medical therapy, also the one who will go for surgery or for angioplasty, with the aim of decreasing the pulmonary resistance of the pulmonary arterial pressure and reducing the risk of complications. These two questions are still open and need to be studied in a controlled trial. Finally, in a single patient, currently we go more for multimodality approach with all the technique combined with a unique target is to normalize the pressures. So asking for direction is not so easy. It's not a straight line. It's more like the magic crossroad like that, where you have at each single points to decide what you will do. But still we are progressing and climbing layers to have a better treatment. In conclusion, Cteph is a rare complication of pulmonary embolism. Why pulmonary embolism does not always resolve is still unknown. The exact frequency of the disease is also not completely understood. And the Cteph can be misdiagnosed as acute pulmonary embolism. This is something very important for the doctors to recognize at the time of this diagnosis. The risk factors for Cteph have been identified. They confirm that pulmonary embolism is at the origin of the disease, and also only a small percentage of the Cteph patients have the most important risk factors for this disease. The diagnosis needs mandatory examinations such as the VQ scan, the echocardiography, the catheterization, the CT scan, and the angiography. And the treatment is based on the pulmonary endarterectomy, the balloon angioplasty, the medical therapy alone or in combination. And they have been shown to improve hemodynamics and exercise capacity and even survival for surgery. Thank you for your attention.
Thank you, Marion. It was really interesting, especially the visuals you provided and the really up-to-date data. As mentioned, if you have any questions, please raise in the chat box so we can answer after these sessions. Now I'm going to help a little bit to Patrick in order for him to share his screen. Now you can try it, Patrick.
I'll try and click over, yeah.
It should be work now.
Is it coming through?
Yeah. The floor is yours.
Great. Thank you very much, Gergely, for the invitation to talk here today. I recognize a lot of my own story in what Professor Marion was talking through there. I do have a picture somewhere of what came out of my own lungs, unfortunately not for this, but you get an idea, I think, of some of the things that I went through. I was a patient of PH. I'm a swimmer. My story is that I started swimming at age 4, and I've done a lot in swimming. I've been a lifeguard on 3 continents, America, Australia, and Ireland. I've been the Irish life-saving champion. I've escaped from Alcatraz. I've done 2 ice miles. And but at heart, I'm a 50-meter sprinter, and I had a dream since I was a child to swim the English Channel. So to go from 50 meters to 50 kilometers takes a lot of effort. And a few years ago, I decided I better start training for this English Channel. And to that end, I undertook the Lake Zurich swim in 2013. And I'll try and move some of these out of the way. And this is a 26-kilometer swim in Switzerland, which took over 9 hours, and killed my shoulders for half the swim. We had a storm in the middle of it. And the following year then I went to do a second swim in the Manhattan Island Marathon swim, swimming around New York. And again, 28 miles, took over 9 hours to do this swim. If anyone's familiar with New York, we swim anti-clockwise around the island. So because I breathed to the right, I swam the whole way around and I didn't see a single thing. But thankfully the guys got some pictures, and you'll see the vastness of the swim here. So again, I suffered with shoulder problems, probably because I went out too fast, treating it like a race, the Empire State Building. On my final swim then, before the English Channel, as part of my apprenticeship, was going to be the North Channel, which is one of the Ocean 7 swims. It just happens to be the hardest of them, and also the closest to where I live. It's from Scotland to Northern Ireland. And while it takes 2 years of a booking period to get an English Channel swim, I took the North Channel on at 2 days' notice. I flew home from the family holiday in Spain, and in September 2014. And the swim is seen as the hardest because of the current, the cold, and the jellyfish. And we say if one doesn't get you, the other will. And so I was swimming along, coming from Spain. The water was freezing, so I'm fighting the cold all day, and I'm also getting stung with jellyfish all day. The jellyfish are the lion's mane jellyfish, and they range in size from dinner plate to bin lid in size. And so getting stung with these, I was trying to put up with the stings. You can see, perhaps make out Northern Ireland on the horizon there. So I was putting up with the stings, putting up with the cold, and you'd say, well, what keeps you going in a swim like this? And a lot of it was the quote from Muhammad Ali, which says, don't quit, suffer now, and live the rest of your life as a champion. And it's a case of how bad do you want it? Well, I wanted it pretty bad, and I stayed in. And after 11 hours, we could see Scotland there on the horizon in front. And but at that stage, after having a great swim up to that point, apart from the stings and the cold, my breathing went, which is very unusual. Now, every breath on a channel swim is a gasp for air anyway. Try and keep the water out and the air in. And with this, when I say my breathing went, it was as if I didn't have the oxygen to turn my arms over anymore, which is an unusual sensation. And really, it was probably the closest I've ever felt to drowning. I had to go on my back to breathe. And after 15 or 20 minutes of this, the guys actually got in and stopped the swim. So to say I was disappointed is an understatement. But after that, my breathing never did recover. And I spent the next 3 months undergoing medical tests to see what was wrong with me. So I went through, I think, 7 tests, an angiogram, an ECG, an echo, a CT scan of the lungs, a lung function test, 24-hour blood pressure test, and a chest x-ray. And all of these said that my heart was fine, my lungs were fine. And I said, but 3 weeks ago I was swimming 20 miles, now I can hardly walk up the stairs, so what has happened? But they couldn't figure it out. Now, notably, I didn't have a D-dimer during those tests, which possibly may have shown up the clots at an earlier stage. But I got so bad in the end that I crawled into the hospital, and they put me in a wheelchair and took me to ICU, where I underwent thrombolysis. Is it thrombolysis, if I say the word right? To dissolve the clots that were dissolvable. And now I told every medic that I met how I got sick from the jellyfish in the North Channel, and that I also wanted to come back and swim the English Channel. And they probably all thought that I was either crazy or deluded, but it was a dream that I wouldn't let go of, and the PEs weren't going to be bigger than my dream. So after a couple of weeks, I got out of hospital, and I spent the next 6 months, I wasn't allowed to lift my son Matthew, who was 3, and I wasn't allowed to exercise. My right heart was twice the size of the left heart, and after 6 months then I could swim but not get out of breath. I was then referred to Papworth Hospital in Cambridge, and Mr. Jenkins, the consultant there, and they did a CPMS exercise bike test on me, and they said the only thing they could tell was wrong was high blood pressure. I was in the top 2%, but Mr. Jenkins said that the MRI told a different story, that 2/3 of my right lung and 1/3 of my left lung were still blocked 12 months later. So in January 2016, 2 years ago, I underwent a 10-hour pulmonary endarterectomy in Papworth. And you can see there the results of that. That's the hospital bed. Now, after the operation, as Professor said, I was sedated for an additional day, I think, because of complications. And then I remember I'm 6'3", but I couldn't stand up straight. I said, you know, the wound wouldn't allow me to stand up. You sewed me up smaller than I am. Each day is a struggle, and initially you can't get out of bed, then you can't walk to the toilet, you can't walk to down the corridor, up the stairs, and everything is a struggle. But as the Chinese say, the longest journey begins with a single step. And after a couple of weeks, I was at home and I'd walk to the shops, and I'd time my walk to the shops, and it was 6 minutes, and I'd try and make it quicker. And then I started to walk to home 10 kilometers from the doctors one day just to see could I do it. And oftentimes you think of, you know, I'm so sick now, I'll never get any better. And this picture's here, my son Matthew, when I won a Junior Harbour Cup, just illustrates how much we can grow in a year. And as adults, I think we forget how much we can change in a year. But for a kid, that's from 3 to 15 months. And to show you how much I came on in the year, I went from the hospital bed in January to jumping in one of the Dublin swimming spots at Christmas. So after I then introduced medical exercise in Dublin City University, which was strength training in the gym. So I was now swimming 3 times a week, 2 kilometers at a time. When I first got in, I couldn't tumble turn, I couldn't dive in, I could feel the wires in my chest, and I was at the back of the lane swimming. But gradually I built that up, and then I added the gym work, and then my boat pilot got in touch, and we'd already deferred the swim from 2015, and he said, how would you like to swim next September? Which gave me 10 months to train for it. And I thought I could, from where I was at, I thought I could train up. So I started increasing the training, and I swam 30 kilometers a week for 30 weeks in a row. And I started swimming every day, which I'd never done before. So on day 208 in a row, I turned up at the English Channel and got in the water at 2 a.m. With my boat pilot, Eddie Spelling. Now, he wasn't there, he was asleep when we arrived. He'd been on a long swim the day before, which means that you missed the tide maybe that you intended to be on. And but again, I wasn't going to let something like that affect me. And now the first 3 hours you can see we're in the dark, and which is a bit surreal when you're swimming alongside the boat. And the next 3 hours, while the dawn came, I spent the next 3 hours getting sick. I couldn't keep the feeds down. We feed every half an hour. And I thought, again, you know, the Ali quote, don't quit, and how bad do you want it? And I'd been through so much that this getting sick had stopped a few of my friends' attempts, but it wasn't going to, hopefully it wasn't going to stop me, but you still think you've got 6 or 8 or 10 hours left of this. And so you just keep swimming to the next feed, the next half hour as you go along. And in the middle then things calm down a bit, and eventually after a few hours, as you can see, we get carried around in the tides there, so you don't swim a straight line. The crew said, we can see France. And I said, what does that matter? Because I could see Scotland, but I still didn't make it. So I tried to keep the focus and not get complacent that I was near the finish, because typically you're not swimming directly for what you can see, you're maybe swimming sideways on the current. And at the end we had the wind picked up to 4 knots, to force 4, and the current was 4 knots. So that gives you an idea of the conditions. And again, so you just keep swimming, and while I was looking at the finish line, there's Cap Brisnay, and you can see the restaurant, which is the low white buildings on the left of centre there. So that's what we're aiming for, but we're not swimming directly for it. And again, we try and keep the focus going, and if this will allow to play, see if I can play the video. I might just bear with me for a second. I knew it wouldn't work when it had to. Just to give you an idea of the conditions towards the end of the swim. Yeah. Hopefully you can see that. So as I say, we're swimming towards the, sorry, bear with me. We're swimming towards the finish, and but again, you can be what looks like a mile away, which would be a half an hour in swimming turns, which turns into 2 or 3 hours against the current. And on the day, there was 8 of us swimming from around the world. Now, that's not going to play for me. I'm sorry. Apologies for that. So if we resume the slideshow, and as you see, getting close to the end, so there was 8 of us from around the world, and from China, Australia, Uruguay, Namibia, the UK, and Ireland. And on the day, only 2 of us made it. And as you can see, after 40 years of trying, 13 hours and 12 minutes, I managed to swim into the steps of the restaurant up in the slipway, and finally I was a channel swimmer. And as I say, I hadn't let PE beat my dream, but it took a lot to get through it. And that's the beach in Dover. You can see maybe on my chest the scars of the pulmonary endarterectomy there. And while I finished as a channel swimmer, and I know that's not everybody's dream, that they either can or want to achieve something like that, one thing, if I leave you from my the last few years, and there's a picture there of Matthew when he was 2 before the Lake Zurich swim, and again when he was 6 before the channel swim. And it's just that while I may have swum the channel, to try and remember to enjoy the little things, because one day they'll be the big things. Thank you very much.
Thank you, Patrick. I think it was an excellent example that you didn't let that the disease change your life, and you could make your dreams come true.
Yes, I'm sorry that the video didn't work, but the technology left it down.
Yes, actually we also experienced some problems with the video during the trial, so we need to somehow fine-tune this. Let us jump to the last session we are going to have. It is going to be a European reference network. Let's try whether our video is going to work. One. I think that some voice should be put on, because we only see the visuals.
Platforms that bring together expertise from all across the EU.
Thank you.
It's accessible to the entire medical community. More than 300 hospitals, more than 900 medical teams, e-health and telemedicine, high-tech cooperation. European reference networks help your doctor find that missing piece of information to diagnose or treat you and many more people like you in the future. Your doctor can offer you advice and provide support with the help of a European reference network. By sharing expertise, medical know-how will rapidly reach new heights, helping patients and their families access better treatments and improving their quality of life. Share, care, cure.
Thank you very much. I think it was an excellent introduction about our last session. It is going to be about ERN Lung. I hope you can see my slides now. So the question is how the cross-border health care directive is implemented. and how, you know, it is working or plan to be working in the near future. So we managed to see, you know, this first slide, the video, which didn't work directly from my slides. That was the reason we make some trick with the techniques. But let's see some background and what type of challenges needs to be addressed in terms of rare diseases. We always make reference to rare diseases or low prevalence diseases. However, you need to bear in mind that there are almost 8,000 rare diseases we are aware of, which impact 30 million people only in the EU. The rare diseases are rather, together with chronic pain, suffering, and usually life-threatening conditions they are. Ultimately, they have a negative impact on the quality of life of the patients. Also, there is also an important point that it is very difficult in some countries, in some regions, to have access to specialist knowledge centers due to the scarcity of the knowledge as well as the fragmentation. And last but not least, we need to talk about access to treatment and care, which is really challenging in some of the countries, member states in Europe. We heard about the video that ERNs have been established, but what is the term we are always referring to? What is the ERN itself? Actually, they are virtual networks of HCPs, healthcare providers. And the aim is that it should be cover any and all member states within the European Union. And it is organized on a cross-border basis. It is also a tool for physicians, clinicians, and researchers to share not only expertise, but resources, knowledge, cross-border, across the EU. The European Commission, when they thought that rare diseases should be generally handled and addressed in the EU, thought that ERNs are the best tool for it. And it seems that HCPs were also open for this solution, because currently more than 300 hospitals joined the different ERNs. It means that over 900 healthcare units are part of ERNs, and the plan is that at the end of 2020, thousands of patients will benefit from the work of the ERN. But let's see how it is work in the practice, because we heard that ERNs are existing, but how is it tangible for the patients? The most important and ultimate goal is to ensure better care and diagnosis. Secondly, it can be managed through new treatments and pathways, which requires trials and research. Through different types of databases and registers, it is also important. So better data will be ensured through ERNs. And we do not need to forget the e-learning and learning possibilities as a result of sharing knowledge. Also important point that through the cross-border healthcare directive, equal access and economy of scale is ensured as well. But you need to bear in mind that the patients themselves will not have a direct connection with specific ERNs. It is also a challenge for the patients that the healthcare itself is managed by the member states, so the patient will receive the care as well as the medication and treatments through the national health system provided by the national healthcare providers, HCPs. As a second difference of line, there's the specific ERNs, which will be, introduced later on. So ERNs are going to provide advice and work as a virtual advisory board for the member HCPs. The basic concept of ERNs is by ensuring e-platforms and other technical solutions that the medical knowledge, the advice, expertise, and data will travel, not the patients. On top of providing advice and providing the virtual advisory service to the HCPs, there are further goals within the ERNs. One of them is to provide guidelines, clinical guidelines, covering all the disease groups. Also, there is an expectation from the ERNs to coordinate at some level of research and to contribute to innovation and knowledge. Need to be mentioned the generating and sharing of evidence through special systems as well as face-to-face meetings. And it was previously mentioned that training both of physicians, professionals, as well as patients are key driver of ERNs. Last year, a special system have been launched which can be used all ERNs within the EU. It is called CPMS, Client Patient Management System, which is a web-based application. I made a print screen about this system, but there is an excellent tutorial available under the below link on the page. It's about a 20 minutes video where both physicians and patient get acquainted with this system and see what type of data can be used within this system, how consultation can be organized. But this tool, you need to be aware, it's rather for physicians due to the strict data protection laws within the EU. On this slide, there's also another picture about how this data sharing is going to work, or actually it is working. It is available for the physicians to make consultation on difficult, unexpected cases. Previously, I mentioned that there are over 7,000 rare diseases we are aware of. And it is also difficult for the European Commission to get contact and keep contact with physicians as well as healthcare providers as well as academia in terms of rare diseases. So they divided the diseases into 24 groups, main groups, and 24 European reference network have been established. You can see with green that there is an ERN Lung. This is our ERN, which is dealing with different respiratory diseases. ERN Lung, as well as other reference network, has a dedicated web page, so you can visit. But I would like to enhance the mission statement of ERN Lung, which is in line with the previously mentioned. So ERN Lung would like to develop the innovative care, relying on cross-border data sharing and care. Would like to develop and provide e-health tools and boost research. Research is quite a hot topic nowadays. There was a workshop organized by EMA and also DJ Sante and the representative of member states were in that workshop. It seems there are a couple of research possibilities are available within the EU. Let's say Horizon 2020, European Joint Research, and so on. And it is expected that going forward, some funds will be only available for ERNs. This is a structure of how ERN Lung is working. Unfortunately, it cannot be seen from the screen because it's very detailed, but you need to be aware that there are horizontal and vertical aspects. There are different so-called functional committees which are dealing on a cross-disease basis and dealing with research, clinical trials, quality management, patient-recorded outcome, as well as training and so on. Also, there is a disease group-specific so-called core networks where we have PH, CF, cystic fibrosis, alpha-1, ILD, and so on. On top of this structure, we have the ERN Lung board and the steering committee, the medical steering committee. It was an expectation from the EU that patients need to be involved in the work of ERN Lung. So there's a dedicated patient board working within the structure of ERN Lung, and patient has also representatives delegated to the medical steering committee. But I would not like to tell you about a fairy tale about the ERN because there are a couple of challenges we have. If you check this map elaborated by Mahambet and Nazareno Gallier, you can see that Central Europe and Eastern Europe are underrepresented in the pulmonary hypertension core network. It needs to be mentioned that this is the case, unfortunately, with other ERNs and with other ERN Lung core networks as well. We firmly believe, that once an HCP or member state join the ERN Lung or other ERN, both parties can benefit from this. We are also aware that being let's say, normal member of ERNs is very difficult and require huge paperwork. We were informed by the European Commission that they expect to have a further call in order to extend the ERNs towards Eastern and Central European member states HCPs. But ERN Lung made a decision, and Pulmonary Hypertension Core Network is really happy to accept application from those countries which are not represented in the core network. This application will not go to the European Commission for official assessment, but it will be assessed by the ERN Lung Medical Steering Committee as well as the Pulmonary Hypertension Core Network. But the documentation requirement will be pretty much the same. So we really urge patients as well as HCPs to reconsider their position and apply for this supporting membership. What is the difference? Many can ask between the members and the supporting members. Actually, almost nothing. What is missing for supporting members is the voting right in the board meeting. Otherwise, they are considered as almost full members. I think we have almost in time, but I'm ready for any questions, not only to this presentation I made, but questions can be raised to Marion as well as to Patrick. If everybody is quite shy, let me ask Marion whether there's any plans or how you screen PE patients where Cteph can can be a high risk. Is there any, special screening programs, or do you have any plans or current experience and practice?
Okay, so that's a good question, and all the medical specialists are busy with that, but we have to take into account that we don't want to do unnecessary examination on a lot of patients, so 97% at the least who will not have chronic thromboembolic pulmonary hypertension after an acute PE. So we need to be more reliant on symptoms. This is what we are doing most of the time, is educating patients in order to recognize early after a pulmonary embolism that there is persisting symptoms, that they are short of breath, that they not do anymore what they did before the pulmonary embolism. And if they have this sort of complaints, then we go for first looking at the ECG changes, the BNP in the blood, and we go for echocardiography. But it's only on the basis of complaints. It's never recommended to do systematic imaging like the echocardio and the VQ scan in a patient who has no symptoms. So this is really in the hands of the patients to follow themselves, in fact, and to it's recommended to the doctor to treat the patients after pulmonary embolism at 3 or at 6 months after. But it's also the role of the patient and the education we give to the patients to compare themselves to what they were before the pulmonary embolism.
Thank you very much for your answer. I also have another question to Patrick, that actually we haven't heard how you have been diagnosed, or how many doctors you have seen. Can you please give us some insights to this as well?
Yes, Gergely. I was referred initially to the cardiologist, and they undertook an angiogram. I think was the first one that they did, maybe, and then ECGs and echoes, and then referred to the lung consultant, Professor Gain. And I think the fact that I was, well, I had symptoms, the fact that I was so fit and young and healthy, PEs maybe didn't enter the equation. So he put me through some of the lung tests, like the lung function test, 24-hour blood pressure test, CT scan of the lungs, and chest x-ray. And it was then that just my symptoms deteriorated to such an extent. I was struggling day to day, and I was told to basically get on with it, and that things would probably improve because my heart looked fine, my lungs looked fine, but that was compared to a normal person, whereas I was a swimmer all my life. So eventually the symptoms deteriorated so bad that I could hardly walk in the door of the hospital. And as I said, they put me in a wheelchair and took me straight to ICU. And each of them would have heard my story, which would have consisted of, if you wanted to think that PEs might have arisen from things like flights. I did have flights from America. I flew home from the family holiday in Spain to do the North Channel, and flew back to Spain and flew home again. So all this was all part of the narrative as we went along. It's just that I was so fit and healthy, and on any normal scale, I looked normal, but I knew that I wasn't right. And actually, when I was finally admitted and ended up in ICU, the headstone of Spike Milligan, the comedian, came to mind, and it was, "I told you I was sick." It nearly felt good to get a diagnosis that people would believe that I wasn't just making it up. And then after that, once they knew what was wrong, it was about treatment and whether I'd be suitable for an operation or not. And even when I did the bike test in England, the CPET test in Papworth, because I performed so well on that, Alice said, "You're too well, they won't even offer you the operation." But then, maybe not thankfully, luckily, the MRI told a different story and I was suitable. But yes, it was, I suppose there was a bit of perseverance in keep following it up. But personally, I think I was deteriorating the whole time. And it just got to the stage where they had to rethink again what I might have. And I did, if you did wish, I have the 20-second video. I think I got it working if you wanted to see what swimming the channel does look like, or if there's other questions, I'm happy to answer them.
I think,
yes, I think
I can make a comment. There are two special aspects in your stories that I didn't cover in my talk. The first one is that still 25% of the patients have never had an acute PE, which was symptomatic enough to be diagnosed, so they come directly with the disease. And the second point is, as you show very clearly, for some very active sporter, they can have symptoms already when there is no pressure at rest. So if you do an echo on a patient like you, there is normal pressure at rest. And so you will see, okay, it's not pulmonary hypertension. While if you exercise the patients, you will see a very important and enormous increase in pressure, which is completely abnormal. And this is an entity that we call chronic thromboembolic disease, because there is no pulmonary hypertension at rest. And we don't know how many patients have that, and we don't know what's the best approach. For you, it was clearly surgery, but for some of them, perhaps it will be angioplasty, and for other, it will be medical treatment. It's still a domain where we need much more knowledge.
Well, just to answer you there, Marion, yes, I think mine was termed exercise-induced pulmonary hypertension, and because of my age, I would have been maybe 41 at the time and had been active all my life. The surgery was a good option. As they said, that the other option was to just play snooker and go fishing for the rest of my life, which probably didn't suit what I wanted to do. And I'd always tried to be healthy, and I suppose I overdid it, but nobody expected the jellyfish to cause this reaction. And when you talk about the blood clots, the P's were the size of satsumas, and I didn't know it was that big or small, not being a medic. And I asked the radiographer, and she said it was the biggest she'd seen. And then the consultant said, well, the coroner had seen a bigger one. So I suppose that's whether they got bigger over the 3 months that it took from first going to the doctors to being admitted to the ICU. They may have got bigger, or whether they were that size the whole time and I just deteriorated. I'm not sure. Nobody can, I suppose, definitively give us an answer on that. But I do consider myself lucky. I suppose not lucky that I got it, but lucky that I was suitable for an operation, able to have the operation, and then in a sport, I suppose, that I could resume. If it was a contact sport, it might be a little different. I'm on warfarin for life, as you say. So my sport allowed me to keep going and achieve a lifetime dream. Yeah. So.
Marion, we also have sorry, then go on. We also have a question in the chat, so.
Yeah, hi Patrick, this is Hall from Norway.
Hi Hall.
It was really interesting to listen to your talk. Do they know the cause of your coughs? Was it the cold water, jellyfish, or?
Yes, basically the consensus is that it's the jellyfish. I had done some cold water swims like ice miles, where you swim in water under 5 degrees for a mile, which in that temperatures and conditions takes over 30 minutes. So I'd done 2 of those. The water in the North Channel was about 14 degrees. So while it's warmer than the ice mile, when you're in for 10 or 11 hours, you're just fighting hypothermia the whole way. Your body's cooling down the whole time. I did have the flights. And again, with flights, they say they're not necessarily an indicator for the clots, and that millions of people take flights around Europe every day. They don't end up with clots the size that I had. I did have a bit of breathing trouble after New York before the North Channel, but that resolved itself. So I suppose it's possible that the flights gave me a little bit of a clot and jellyfish made them worse. I think the example that the hematologist gave was that a snake bite can kill you by either clotting the blood or thinning the blood, and both can kill you. So effectively the jellyfish stings, and some of my friends doing long swims, they've had breathing difficulties after jellyfish. When I went to the doctors, 2 people had tried the North Channel the same week as me. At the time, only 20 people in the world had swum it, so that's how rare the swim is. One was hospitalized and this x-rayed her lungs and said she had the lungs of a 6-year-old man smoking 60 a day from the jellyfish. And she was in hospital for 2 days and released, but went back to hospital in America with fluid on the heart and lung, liver trouble, treating her for pneumonia. She was on morphine and go to monitor for 6 months. And the other chap got out after 8 hours and said the jellyfish rot his heart. So when I went to the doctors, I was telling them about these 2 other swimmers. So they were looking for their problems, and me, I just had a different problem. So I guess the hematologist says, in order to rule out that I didn't have a genetic predisposition to it, or that it was like, you'd have to take me off the warfarin to do the tests, and they don't want to do that. So what was different this time was getting stung for 11 hours constantly with jellyfish stings, and some jellyfish can kill you, ones in Australia and that. So the feeling is the flights may have had some minor impact, but the jellyfish is the thing that did it for me. That's how my body reacted. Your body may not necessarily react the same way, and I think that's the best consensus.
I noticed you had small swimming trunks on. Couldn't you have that protective gear to protect yourself from these jellyfish?
Yes, when Gergely said he'd like me to do a talk, I said, you realize it'll just be a bunch of pictures of me in my Speedos. The channel swimming rules are that you wear traditional swimming costume, 1 hat, 1 goggles. So again, 2 or 3 hats would keep you warm. A wetsuit would keep you warmer, or even the long lycra suits that they used to wear in the Olympics. They're kind of currently banned because they're seen as being too assistive for the sprinters. We're not allowed to wear any of those. It's against channel swimming rules. So we're traditionalists, I guess, and if you want to be classed as swimming the channel, this is how you do it. So you saw the boat there, and I'd have 6 people on the boat: the pilot, his crew, 2 crew, my 2 crew to help me, and then an observer from the association. So we don't make it easy on ourselves, and you're up against nature, be it the cold or jellyfish. And as I say, jellyfish in the Bahamas or Hawaii, one individual sting might hurt you a lot more than mine hurt. It's just a community over the day. This is the effect that mine had.
Are you totally symptom-free now? Are you as good as before you had the cough?
I wouldn't say I'm as good as before. Sometimes I might go up the stairs and think I'm nearly out of breath, and then I say, is that just age or fitness? I suppose swimming fitness is different to running anyway, but largely I'm symptom-free. I know from my times in the pool, even though I'm doing as much training, I'm not as good at sprinting. Some of that is getting older and not having done sprint training for a while, but I think some of it also is down to my lung capacity is not as big as it used to be. But I suppose my swim, I'm able to continue swimming, be it either shorter distances or these marathon ones. So I've been lucky that way that my sport allows me to compete, but I don't think I have exactly the same lung capacity as I would have had before.
Okay, thank you. Gergely, I had a question to you and ERN. As you know, I live in Norway, and Norway is not part of the EU, but they are closely connected to EU in many ways. Can Norway take part of ERN, or are they excluded?
That's a very good question. Can you hear me?
Yeah.
Okay, so that's a very good question. I think that it should be raised because we haven't, investigated this type of situation, because Switzerland might be, also impacted, and I know a Swiss guy, a patient rep who is really active in the ERN Lung, but I'm not aware of whether he's connected through EU-based HCP or from Switzerland, because there are bilateral agreements between, Switzerland, Norway, and the EU. In what part can such countries take part in common EU initiatives? So I will write this, question and find out and come back to you, because I do not know it by heart.
Actually,
we are still UK in the ERN.
Yes, they always receive, questions and tricky, some tricky questions, how they are going to plan to be part part of ERNs, but you know, it's a question of the negotiation between EU and UK, how they are going to implement, or how it is possible for them to be part or remain part of ERNs.
Mm.
We also have a very interesting question from the chat. It is addressed to Marion, that how you determine whether a BPA or a thromboectomy is needed, and which is better or convenient, more convenient for the patient, or how you determine these type of, you know,
So it's a good question, and perhaps the response will be different within a few years. But at this time, we still first look if the patient is operable, because in one time you can really nearly cure the patients and remove all the material. And we have very long-term data, up to 10 years and more, showing that the disease is not coming back and that the survival is improved. For the BPA, it can be very efficient, as you have seen from the slides, but we have only 5 years data. We have not complete data, so we have probably a selection of patients who are well and not the one who have not improved. And so at this time, we cannot recommend that BPA could be the first strategy. Also, you have to know that BPA, it's not one single procedure. It is from 5 to 10 times 2 hours on a table where the catheter is manipulated to do the dissection. It's always possible that to have some complications. So it's not the solution for everybody, clearly.
I had a question about this operation. If you can go in with balloons, wouldn't it be possible to go in and kind of break up the cloth and suck it out?
It's very hard material, which is really inserted in the wall of the vessel. So breaking and so on will not remove the burden. You have seen my slides of the material, which can be very extensive. And so this is when it is very close to the heart in the big branches, it cannot be pushed on the side. It's too much. It's a very huge amount of clots. And so we better remove them. And a fragment is not a solution, because if you fragment it, you will still keep all this material in the vessel, and it's not, you cannot dilute it. It's really like a piece of meat.
As I heard, we have another question. I cannot recognize the voice. Who was that? Or probably it can be raised in the comment chat, and I can read it.
I don't know. Can you hear me?
Yes.
Hello. Good afternoon. This is Juan. I wrote a question because it seems that my microphone was not working. I don't know why. So ERNs and cross-border directive intend to reduce inequalities, but that objective cannot be achieved without equal access to medication across Europe. Do you foresee that ERN Lung will take a stand on this issue at some point?
I think it's a very good question. I do not know who is your addressee, Marion or myself, but as you may be aware, the healthcare as it is remain in the member states' responsibility. So it's a very tricky question once you have an advice from the ERN Lung that the patient should be treated with the following medication and treatment. However, that type of medication is not available at that specific member state. I do not know how it will work out, or how it will be addressed or solved in a very short time. But you are right that it's a huge barrier for being effective and using all the possibilities ERN Lung can provide to rare disease patients.
Well, the second question is related also to this. If, and mainly it happens in Eastern Europe countries, if there is no access to medication, how can they possibly meet the requirements to belong to ERN Lung? Because they will not have the standard of care. The centers, I mean, the centers in those countries.
You know, it probably it was one of the problems why HCPs from Eastern and Central Europe have not joined to the ERN Lung due to, you know, some of the requirements that they cannot fulfill. However, you need to be aware that there are, you know, lots of quality and quantity data you need to provide, you know, for to be accepted as a member of the ERN Lung, and it was assessed by the European Commission. But as I mentioned, there is a possibility to be part as a supporting member, and you know, ERN Lung as well as PH Core Network is aware that there are, you know, centers in Central and Eastern Europe following the guidelines, as well as, you know, all the applicable principles. However, they cannot meet, let's say, the number of patients cared or the new patients per month requirements. So this is the reason we try to open the gates for those, you know, countries and ACPs to benefit from ERN Lung. I do not know whether it is an answer to your question.
It is. Thank you. Thank you very much.
If there's no further, you know, question which remains within you, let's give another try to this video, and we will close, you know, our session, our webinar with this, you know, little insight how the channel swimming had been for Patrick and how challenging it was.
Now, hopefully this will work.
Okay.
Can you see it now?
Yes, but the video has not started yet.
Oh, sorry. I'm just trying to get things out of the way. So it takes just a second to start. As you can see from the conditions, that's the force 4 kicks up a bit of a wave, and anything that isn't flat cam, you just try not to swallow water on each breath. In 13 hours, 12 minutes, at 60 strokes a minute, it's about 50,000 arm strokes to reach France, and hopefully that gives you a glimpse of what's involved every step of the way.
One final question to you, Patrick. It's for data lovers. What is the average speed you were swimming? I mean, how many minutes per 100 meter? I think that this is the how you measure the speed of swimming.
Yes, in the pool, I can do just over 4 kilometers in an hour, which is 1 minute 30 for 100 meters. My PB, that's a training speed, so that's typically a training speed, 1 minute 30 per 100 meters. PB in the pool is 59 seconds, and 26 seconds in a 50-meter race. But when you're in the sea, it's probably a little slower. It's probably more like 140 per 100, 142 per 100, simply because you're not trying to keep up the fast pace for so long. So one of the things I learned from doing Lake Zurich and Manhattan was that I could keep up a fast pace for 3 or 4 hours, or maybe 6 hours, but then I got fierce shoulder trouble for the last 3 or 6 hours of both those swims. So by heading out a little slower and having done more work, I was able to complete the channel without largely without any pain. I did have a sore wrist for a few days after it, just from, as I say, 25,000 arm strokes in each arm. So, but about 140, 142 per 100. It's a little difficult. It's 21 miles in a straight line, which 33 kilometers, but the GPS actually had us doing over 50 kilometers because we don't do a straight line. Does that give you an idea?
Yes, thank you very much. So I really would like to thank for our speakers to devote their valuable time and make such a very interesting presentation. Please note that this webinar has been recorded and it will be made available through our channels. And happy weekend to everybody. Thank you very much.
Okay.
Thank you very
Bye-bye.
much.
Good weekend.
Thank you. Bye-bye.